relationship between the pretest probability and the positive predictive value. See if I can move this here. Perfect. The only conflict of interest that I'd like to divulge today is that I am an advisor for Bayer in the Women's Health Division, but that has no implications with what I am speaking of today. I'd like to begin with a couple of disclosures. In this presentation, we'll address concepts that are certainly well known to you. However, following a quick review of these ideas, a novel theory will be introduced. I suggest really not to get bogged down in the mathematics of it all, but rather to get a more global perspective that hopefully will impact how you think about the issues faced herein. We'll talk about calculus, we'll talk about trigonometry, aviation, politics, philosophy, conspiracy theories, and marriage. It's not a typical Thursday, I give you that, but I hope it's an interesting one for you guys nonetheless. So without further ado, here we go. We know that the role of the clinician are multifaceted. There are many roles that a clinician has. However, I think all roles can be said to stem from the most fundamental one, which is determining whether an individual is healthy or is sick. And to accomplish this, amongst many other things, we run tests. The question then becomes, do we really understand the testing process? And that's what I hope to speak a little bit about today. For that, we'll review some of the concepts that you're certainly familiar with when we talk about screening. As you know, screening is defined as the presumptive identification of unrecognized disease in asymptomatic individuals by means of tests, examinations, or procedures. And when conducting a screening test, 4 different parameters, at least 4, help to determine its overall ability to correctly identify individuals either with or without the disease in question. And this process is subject to the WHO's Wilson-Jungner criteria for screening tests. What are these parameters? You all know them very well. Sensitivity, which is the true positive rate, essentially asking the questions amongst patients with a disease, how many will have a positive test? The specificity, which is the true negative rate, asks the question amongst patients without a disease, how many will have a negative test? On the other hand, the positive predictive value, and these are parameters that are a lot more useful to the clinician at the bedside, asks the question, amongst the positive test, how many patients will actually have the disease in question? That's more interesting, a clinical question for us. The negative predictive value asks the same question, but in reverse. In other words, amongst negative tests, how many patients will not have the disease? So once again, sensitivity, you talk about affected patients, and then you ask how many would have a positive test if they were to be tested. Whereas the positive predictive value, you somewhat inverse that relationship and you say, well, amongst the positive tests that I've received, how many are actually truly affected patients? And for that, we need to talk a little bit about Bayes' theorem. Certainly, many of you have know Bayes' theorem well, but we'll talk a little bit about it quickly. Bayes' theorem has been dubbed sort of the equation for knowledge. It is amongst the most powerful equations in science with widespread applications in virtually all facets of life. Is the mathematical theorem that essentially provides the relationship between the screening parameters that allows us to calculate positive predictive values. And more specifically, it provides the probability of disease after accounting for the sensitivity, the specificity, and the baseline risk for the condition in question in a given patient. And the equation is fairly simple. It looks a little complicated because there's some signs that are not standard notation that we see on a regular basis. But essentially, here you have 2 events, which are A and event B, and this could be quite literally anything. And the little vertical bar that you see there essentially speaks of the conditional probability, essentially stating here, P is the probability of A, given that B has already happened. And here is the opposite, and that's equal essentially by Bayes' theorem to the probability of B, given that A would have already happened, times the probability of A over the probability of B. And these are the independent probabilities of A and B. Now, that sounds a little convoluted. I'll give you a quick example using something that is not medicine or screening related, but essentially, if you think about your next trip that you're going to take, you can ask the question of, your event or your claim can be, for example, what A would be a flight that arrives on time, B is a flight that leaves on time. And so the question then becomes, well, what is the probability that my flight will arrive to its destination on time, given that it left on time? And the equation for that to calculate, you have to essentially calculate Well, it is the probability of the flight having left on time, given that it arrived on time, multiplied by the independent probability of a flight arriving on time over a flight leaving on time. And if you look at some values that you can find easily on the internet, a probability of a flight arriving in time is about 80%. The probability of a flight leaving on time in North America is about 83%. The probability of a flight having left on time, given that it arrived on time, is about 78%. And so you can easily calculate the question, which is what is the probability of a flight arriving on time, given that it left on time, and you multiply as per the equation, and you get about a 75% chance. And so this is a very powerful, but yet simple way that we can use data that's readily available and calculate conditional probabilities. Now, how do we apply this theorem to screening? We can use an event as having a positive test. We can use an event as having or not having a particular disease. So instead of talking about A and B, let's say we talk about D as in disease and T as in test, and we a little positive just to state essentially that the patient does have the disease and does have a test. That equation that you see above actually translates to the equation that you see below, which is essentially a calculation of the positive predictive value, which asks once again the following question. Given a positive screening test result, what is the probability that an individual does in fact have the disease in question? So that's the PPV, that's the positive predictive value. The probability that a test is positive given that a patient has the disease, we have just gone over that, and that is actually the sensitivity of the test in question. The probability of disease, it's an independent probability. If we look at general populations, we could talk about the prevalence of disease, or if we talk about an individual patient with particular risk factors, we could talk about the pretest probability. Let's say, for argument's sake, we talk about prevalence here. Down on the bottom in the denominator, essentially, you have this same factor there, it's sensitivity times the prevalence. And you have a little modifiable factor here, which is the presence, the fact that you have a positive test, given that you're not have the disease. What is that? That is essentially a false positive, and that is equivalent to 1 minus the specificity. So it's the complement of the specificity, and the probability of you not having the disease essentially is the complement of the prevalence. And you'll note I told you these two equations are equivalent. How come our denominator is that much longer than the denominator in the sort of Bayesian theory for the general case? Essentially, they are equivalent by the law of total probability. It's just a nicer, easier way for us to depict the screening equation using the parameters in question. And so you can reduce that equation, essentially, instead of speaking about conditional probabilities, given that we have names for these parameters. And so from now on in this presentation, A will be the sensitivity and B will be the specificity. And this little row and this little phi here would be sort of the prevalence or the pretest probability. So once again, sensitivity times prevalence over sensitivity times prevalence plus the complement of the specificity and the complement of the prevalence. And that gives you a positive predictive value. We know based on this equation, essentially, that the positive predictive value, which is really the most critical statistic necessary to interpret a screening test result, is proportional to the sensitivity, to the specificity, as well as to the prevalence of disease. It's technically inversely proportional to the complement of the specificity, and that essentially just means it's proportional to the specificity. Again, we make a distinction between prevalence and pretest probability. I'm sure you're all familiar with, but the pretest probability is defined sort of as the risk of disease at the door for an individual patient. So it is highly specific. The risk of diabetes, for example, in a patient with obesity and a positive family history and poor dietary habits is not the same as in a marathon runner with a strict diet, obviously. And so the pretest probability, we say, is higher in the first individual than in the marathon runner. And prevalence is therefore but a specific case of the pretest probability when it is assumed that the risk of the disease is either unknown or assumed to be that of an average individual in the population. Now, Bayesian terminology and Bayes' theorem, like I told you before, is really ubiquitous. It's used in many, many fields. And so it is not surprising that there are, in fact, different terminologies that are used in a different field. For us, when we talk about the screening terminology, a positive predictive value is essentially equivalent to the posterior probability. The prevalence is equal to your prior probability, or the pretest probability also is equal to the prior probability, depending on the context. The sensitivity is essentially your true positive rate, and the specificity is the true negative rate. That's sort of the base stuff that you guys are already familiar with. Now I want to move on to something a little bit more new, perhaps that you haven't been exposed to before, and this is what we're working on on the lab. We have just seen, once again, that the positive predictive value is proportional to the prevalence or the pretest probability of disease. But proportionality actually has a very specific definition. It implies changes in the same direction. As one increases, so does the other, and vice versa. The question is, though, what is the nature of said proportionality? And using Bayesian principles, we can attempt a thought experiment outside of the medical field, which hints at the nature of such proportionality. And for that, we've developed something called the marital status thought experiment. The marital status thought experiment asks the following question. Let's say that you see, for example, a person walking down the street. And let's say that I ask you then, what are the chances that that person is married? As it stands, you have really no idea, right? You have no data that is specific to that person. However, you can surmise the probability based on a number of factors: the appearance of the person, if they're, a child, maybe less, if it's a person that's, walking in a neighborhood that is not necessarily very family oriented, but more of a, hanging out place for young kids, whatever it is, then that probability probably would decrease. It could be also a matter of what time of day it is, what your intuition is telling about what you know about marriage and what the person is sort of portraying. Now, the interesting thing here is those are your priors, right? That's what you otherwise would be your pretest probability, because you haven't really quite yet tested the person, you haven't interacted with them, you haven't actually applied any kind of a test on them to see whether they are married or not. And in this case, testing essentially would imply receiving more information and using the marriage test, quote unquote, to determine whether it is likely or not that they're married. What does that mean? Well, a screening test essentially will update your pretest probability to achieve a positive predictive value. So to make this a little bit more clear, I'll walk you through the thought experiment so that maybe the point I'm trying to bring forth is actually clear. Again, you see the person walking down the street and I ask you, what is the chance that the person is married? You'll give me a percentage, whatever it is. The value itself is less relevant to the idea here. Let's say then, and in a second scenario, I tell you that now they're holding the hand of another person. And let's, for entirely generalizable and argument's sake, it's a person of the opposite sex. What are the chances now that that person is married? Well, again, you wouldn't be able necessarily to give me a number, but certainly the chances is higher. Say now that there's a child in between the couple. What are the chances that the original person that we spoke to is married? You say would go up. Let's say then that each of them are wearing a wedding band. What are the chances now that they're married? Essentially, it goes up. What if you check their IDs and realize that they share an address at home? Yeah, it goes up. And you could do this exercise ad infinity. They could show you pictures of their wedding. They could show you a marriage certificate. You could always get more information that would then come and confirm or affirm, rather, your initial hypothesis by updating those prior beliefs that you had about the person. But the question is, where do you stop? How much information do you need to be persuaded the person in question is married? And this is true in all facets of life. Intuitively, we know that in order to recognize or identify the presence of an object, a pattern, or even an abstract construct like an illness requires some input information. We likewise have all experienced situations whereby the amount of information necessary to reach a persuasive conclusion is often only a fraction of all of the information that's available. And this becomes therefore a problem of analyzing all of the information available and optimizing the inference process to reach a conclusion. So once again, how much information is enough? So back to the proportionality. We've noticed that beyond a certain point, adding new information doesn't significantly increase your likelihood that the person is married. Indeed, not all information increases the probability of your conclusion being valid in the same way. So otherwise stated, the proportionality is not linear. How can we prove this? Well, we can prove it visually. Let us then, for argument's sake, plot that screening equation for the positive predictive value and then analyze its geometry. Again, you see the equation up here. And this is sort of this equation plotted as a function of your prevalence or your pretest probability. And on the vertical y-axis, you have the positive predictive value. And so essentially, you see that this is a square of dimensions of area 1, right? Dimensions 1 by 1. And the shape of the curve essentially is not linear. As you can see, is in fact curvilinear, because an increase in prevalence on the x-axis does not confer an equal increase in the y-axis. And therefore, we can conclude that it is not linear. The exact shape of this curve, and I'll show you in a minute a more dynamic model, is dependent on the sensitivity and the specificity of the test in question. And again, notice that range in the domain of this function, which is both spanning 0 and 1, creating that square plane. This brings us to the first theorem that I'd like to speak to you about, which is what's sort of become known now as the fundamental theorem of screening. The fundamental theorem of screening, again, I don't want to get bogged down in the math and the mathematics of it all, but it's fairly straightforward, where we define a new variable, let's say epsilon here, be the sum of the sensitivity and the specificity. In other words, A plus B. We say here that the limit, okay, as epsilon, as the sum of the sensitivity and the specificity goes to 2, that is to say, as you have both a sensitivity of 100% and a specificity close to 100% as possible, then the area under the curve, and that's what's represented by this integral here, between the domain of the function, which is 0 and 1, of that positive predictive value equals to 1. What does that mean? It means that as the sensitivity and the specificity each approach 100%, which would be defined as quote unquote a perfect test, the area under the curve of the screening equation goes to 1. In other words, as the sensitivity and specificity are maximized, so is the positive predictive value maximized as well. And for that, I would like to show you, I have to stop sharing the screen to show you a dynamic, and I'll share it right back. If I do this, you should be able to see this. Do you guys see the graph now? Sorry, I don't know if somebody can tell me.
Yeah.
You see? Okay, perfect. Thank you very much. So forget about all the numbers on the left side. Essentially, A and B here are the sensitive specificity. You notice that if I move the specificity around, the curve changes, right? And if I move the sensitivity, also the curve will change. Now, this happens to be because of the way that the math works out, a little bit more sensitive to changes in specificity than in sensitivity, but nevertheless, both actually will change, as you can tell, the area under the curve, noticing that both the endpoint here at 1, 1 and the origin at 0, 0 don't actually change. And this is independent of your prevalence or pretest probability and your predictive value. So look at what happens, for example, when I bring my values all the way up to 100%. In other words, you get a perfect test. And here, I'm going to move the specificity. Essentially, what you get now is a straight vertical, horizontal line, which implies that prevalence or pretest probability no longer has an impact on the reliability of your result, because you're always getting a perfect result, right? You're having essentially a perfect detection test with the screening. Then the moment you start moving, then you get that curvilinear relationship again, and you have an area under the curve, which gives you an area that isn't covered, which essentially leaves room for quote unquote error. Now, I'll go back to the presentation so that we can move over where we were. And for a myriad of reasons, as I'm sure you know, many of which involve human error, sampling mistakes, and patient variability, we can't really obtain a test with perfect sensitivity and specificity. So this idea that a perfect test exists, we probably should be dissuaded of, at least in the practical sense. So let's go back to this curve. As you can tell, there is a critical point on this graph. It's sort of a cliff, if you will, below which the positive predictive value will drop most precipitously, and beyond which it doesn't change much, okay? And you can tell it's somewhere around this area, which is where the red dot is, which essentially when you keep adding prevalence, or when you keep adding pretest probability, or when you keep having priors, you see that your positive predictive value is essentially flat. And the more pronounced that the inflection point here, in other words, the better the test, the more pronounced that inflection point, and the more that horizontal line is seen. And so you can essentially draw a vertical line from that point down to your x-axis and determine at what prevalence or pretest probability you get to that threshold. What does this actually mean clinically? It means that beyond that point, if you were to assume, for example, in this case, that your patient had a risk, say, I don't know, maybe this is 16, 17% of diabetes, and it's certainly higher, then if you get a positive screen, you know that you're probably in the green area, and that you can be fairly reliably assured that the patient in question, for example, does have diabetes, if that's what you're looking for. As per that fundamental theorem of screening that I was speaking to you about before, improving that sensitivity therefore improves the area under the curve. And this not only sharpens the inflection point, but also lowers the prevalence threshold, right? It will bring it essentially closer to the y-axis. And so I'll show you again sorry, here we go. I gotta share this. I'll show you again in the graph. Sorry about that. In the dynamic graph, so you can see it in real time, where I'm going to plot here the prevalence threshold. And you can see that as I move, for example, this closer to 1, the specificity, the line essentially goes to 0. In other words, you do not need any prevalence to get a perfect test. The moment you start moving, and for example, here, look, I have 100% sensitivity and 99.3% specificity, and I still have that line because there's still, despite that excellent test, room for error, given that this is dependent on the prevalence or the pretest probability of disease. So here we go. Now, how do we calculate that prevalence threshold? In other words, because that's not just a geometric thing, it's really an arithmetic thing where you can find an equation that will give you that all the time. I won't get into the details of how we go about it, but essentially we use geometry, and essentially the point of inflection that you see there is the point of maximum curvature. And curvature is essentially where we delve into calculus, right? We take a differential equation, you take the second derivative of that screening equation, and you can plot it into this simple differential equation here, where you get the second derivative over 1 plus the first derivative squared, all to the 3/2. How we get to that point, it doesn't really matter, but essentially when you do that, you derive that equation for curvature, then you find the roots of that equation, and that spits out a value of pretest probability or prevalence, if you will, that is fairly simple to compute and to calculate. Once again, here B is specificity and A is the sensitivity. And this is what we call the prevalence threshold. You take the square root of 1 minus the specificity over the square root of 1 minus the specificity plus this little modifying factor, which is 1 plus, which is the square root of the sensitivity. So once again, square root of 1 minus the specificity plus square root of 1 minus the specificity plus the square root of the sensitivity. And once you have that, then you can use any test whose screening parameters are known, plot that into this equation, and this will tell you essentially at which point of prevalence that test essentially starts to fail or starts to yield increasingly false positive results. The publication for this idea is actually in the Public Library of Science 1. It was published last year, and it's open access, so you guys can access it if you're interested to find out a little bit more about how we derived that equation. But to sum up, the prevalence threshold is really the prevalence or the pretest probability level below which the positive predictive value of a test drops the most rapidly. And if the prevalence drops enough, it may be that most positive screening tests may in fact be false positives. And also, if we're testing patients whose pretest probability falls below this threshold, we're likely to obtain a significant number of false positives, which actually increases costs, stress, and resource allocation. Here you have two curves, again, two screening curves plotted, each with different sensitivity and specificity parameters, but this time one next to the other. Once again, a lower area under the curve means a higher prevalence threshold, means a poorer test, means that you need to have a higher degree of suspicion or pretest probability to suspect that somebody is, for example, sick with a condition that you're testing for to obtain reliable results. So we call that test, quote unquote, worse because that inflection point, as you can see, there is less pronounced. So let's give you something a little bit more clinical so that this all becomes a bit more tangible. Let's say, for example, a colonoscopy, which is a common population level screening test that is provided indiscriminately to the population at large. Again, I have made several generalizations because obviously there's not a single sensitivity and specificity depending on the studies and the population that you look at. But on average, a colonoscopy can have a sensitivity of about 95% and a specificity of 86% to detect colorectal cancer. When you plot those two values into that equation that I gave you, it gives you a prevalence threshold of about 28%. What does that mean? It means that below a risk of 28%, you are likely to obtain, again, how close you are to that threshold might decide how likely it is that it is a false positive, but essentially below that threshold, the test becomes increasingly unreliable. However, I've just told you that you do this at the general population and you have a prevalence of colorectal cancer. And then that is a lifetime prevalence of about 4%. Okay, so that's 7 times less than what the prevalence threshold would hold, essentially yielding a positive predictive value of only about 22%. What is to say that anytime you call a colorectal cancer from the images on a colonoscopy, you're likely to be right maybe 1 out of 5 times. And that's, like you can imagine, extremely stressful for patients to hear, but it is something that we don't actually master, I think, as clinicians, to talk about risk in a way that can convey that degree of uncertainty when you're doing screening and not diagnostic testing. What about a mammogram? Mammograms, again, varying sensitivities and specificities, but you see here how the values have shifted, right? The mammogram has a lower sensitivity and a relatively higher specificity. And I had told you that screening curve is a bit more sensitive to the specificity. So essentially, you're getting a lower prevalence threshold, which is not far from the colonoscopy. It was about 25%. Now, breast cancer lifetime prevalence is about 12%. And again, giving you, in theory, which is not a good measure of the prevalence for an individual patient on any given point, but let's just assume for argument's sake that we are calculating the PPV in a risk, in somebody whose risk is 12%, it's still giving you about a flip of a coin. It's about 57% chance that a mammogram that gets called suspicious, a BI-RADS 4 or more, that you might get a false positive. Again, differences in the prevalence threshold as well. What about a Pap test? Pap test we do in my specialty all the time. 43% sensitivity, not a very sensitive test, great specificity, but even at that, 21% prevalence threshold when the prevalence of cervical cancer is less than 1%. So you're having very, very poor predictive values when you're running these tests indiscriminately. And this is the regular old Pap test that we know it's sort of falling out of fashion nowadays. But nonetheless, the example remains. Bone mineral density, once again, similar relationships where you have a prevalence threshold significantly higher than the prevalence. So you're getting significant of false positive. NIPT is the non-invasive prenatal testing. It is by far one of the best tools that we have as obstetricians to detect trisomy in babies. Has fantastic sensitivity and specificities, which even in some manuals are quoted as to having 100% specificity. It's not really the case clinically that you see sort of practically speaking. But even at that, because the risk of trisomy in the population is so low, and again, this is age dependent as well, so I'm making several generalizations, you're still getting a positive predictive value of only about 60%, even though your prevalence threshold is about 3%. It's just that the 3% is significantly higher than the 0.002 here. So you're still getting significant amount of false positives. Fecal occult blood testing and the PSA for prostate cancer, you see, once again, same relationship. So you can note that all of the prevalence threshold values lie above the prevalence levels of each condition. And this implies that there is a significant proportion of false positive tests when these tests are run indiscriminately as part of public health programs. I don't have to tell you that adds cost, that adds stress, that adds delay to the system. And if we could find a way to navigate that and perhaps be able to better identify individuals at risk to actually undergo these kinds of screening tests, I think we go a long way in avoiding the long wait times that we have to access sort of the most basic care that we need in places where medicine is easily, otherwise publicly accessible. Now, I'm going to talk to you a little bit about more of that curve, because essentially the presentation is really a lot more about the geometry of those curves. And this is a theorem on the angular definition of the positive likelihood ratio, things that you probably have not seen yet, but the likelihood ratio, of course, you're all familiar with. The positive likelihood ratio is defined as the likelihood of a positive test result in patients with a disease divided by the likelihood of a positive test in patients without the disease. It is amongst the most fundamental of statistical parameters that we use in epidemiology. And we can write the likelihood ratio as a function of the sensitivity and specificity as follows. It's the sensitivity over 1 minus the specificity. Interestingly, there is a nice correlation between the prevalence threshold and the likelihood ratio in the following way, in that you can rearrange or rewrite the prevalence threshold equation as a function of the likelihood ratio, or the positive likelihood ratio at that. Essentially, it becomes even a lot simpler. It's just 1 over the square root of the likelihood ratio plus 1. And that would also, at any given time, give you the prevalence threshold level, or the prevalence level below which these tests start to fail. Essentially, these are the steps. You take the screening curve, it's in blue here, and this is just a random screening curve that's generated with some sensitivity and some specificity. You determine, based on that equation, the prevalence threshold, and you drop it down here. And then you draw a line from the origin to the prevalence threshold, and then from that prevalence threshold back to the y-axis, you get essentially an angle. That angle is called beta. When you take the cotangent of that angle, you get the likelihood ratio, the cotangent square. That's not something that you have to do clinically, but it's just a way, if you're ever faced with a curve like this on a paper somewhere where the values are not immediately clear, essentially you can measure this angle, take its cotangent square, and that would give you the likelihood ratio of the function that you're seeing. So it is essentially a different way to assess how good a test is. The third theorem is a theorem on the special case of the geometric definition, where here, essentially what we're doing is the same exercise. We're determining the prevalence threshold of a screening equation, drawing that vertical line, then drawing a line from the origin to that point, and then from that point to the endpoint. And you get essentially two lines, right? Two linear functions. When you take the slope of the blue over the slope of the red, then again, you're getting the likelihood ratio as well. And finally, this happens to happen to be the case at the prevalence threshold point, but it turns out, if you look at the mathematics of it, this is true at any point. You can draw a point from the origin to, let's say, here, and from here back to the endpoint, and then the slope again of the curve above to the line below will still give you the positive likelihood ratio. The fifth and final theorem that I want to discuss with you, and the proofs of these theorems are all published, and I can give you access to the references if you'd like. But the main point that I want to bring is that you can look at the geometry. A visual inspection of a screening curve can actually give you very, very valuable information that otherwise would not be accessible to you, having to calculate essentially sensitivity and specificity parameters. Finally, I'd like to leave you with something perhaps a little bit more stimulating, more philosophical in nature, and more, I think, interesting for the general applications in life, not so much only in medicine, but these are sort of the theorems on the sum of the Bayesian prior and posterior. As we alluded to before, Bayesian theory is really ubiquitous in life. The pretest probability, or the prevalence, is really only a type of prior probability, but the priors really apply anytime that we assess the world around us. And we assess the evidence presented, and then we update our prior beliefs to obtain a posterior belief, or what it is, the positive predictive value in the screening sense. And this is in a way to attempt to arrive at some truth. Then that posterior can become a new prior when new evidence is presented, and then so on and so forth. This is a bunch of screening equations with different sensitivity and specificity parameters put on that screening plane. But note that regardless of the sensitivity or specificity combination, all prevalence threshold points of maximum curvature lie along the y equals 1 minus x line. It's essentially a diagonal line on the starting high on the y-axis and then ending here low on the y as the x develops. And essentially, I just told you the y is your posterior, the x is your prior, or rather the y is your positive predictive value, and the x is your pretest probability or prevalence. When the sum of those two equal 1, then you know that you are at the prevalence threshold. And so, in other words, at the prevalence threshold, the pretest probability plus the PPV equals to 1. If the prevalence threshold tells us at what level we can be certain, or more certain rather, about the validity of the test results, then outside of screening, this threshold can act as a more general information threshold. And I bring you back to that marital status thought experiment where at some point you said, okay, no, I'm persuaded, I'm convinced, I don't need any more information. Here, it's prior plus posterior equal 1, but it's the same thing. And this is a branch essentially of decision theory about how human beings make decisions and how we are persuaded about the decisions that we are making. And otherwise stated, when your degree of certainty about a claim is high, then the amount or the quality of evidence that you need to validate your intuition is low, and vice versa. And this has significant philosophical and epistemological implications in decision theory. And this may very well explain how we become persuaded that some claim is true, but it also may lie at the core of how conspiracy theories are propagated as well. For example, say that you've been exposed to repeated, partisan, baseless claims of fraud committed by a politician of an opposing party by either watching the media or speaking to trusted people or reading some material which offers no concrete proof. Say then that some event happens which even raises the possibility that fraud may have occurred, but for which the quality of evidence is actually quite poor. And you don't have to look very far nowadays to look that a lot of these things are actually happening in the world around us. The person whose prior beliefs about such a politician was already high needs very little confirmation of those beliefs to be persuaded of the veracity of such a claim. In other words, their degree of pretest probability was already high, such that what they need for a PPV can actually be quite low. We counter this by always keeping low degrees of prior beliefs and relying mostly on high quality evidence to navigate the world. And I think that's probably what we should all do. In other words, let the chips fall where they may and just follow the truth. So how can we use the prevalence threshold? It ought to serve the clinician, in my opinion, to distinguish where an individual falls in the pretest probability risk spectrum. If the risk is truly below the prevalence threshold, such as amongst patients with no symptoms or risk factors, a patient's results may not be reliable, and counseling should reflect this fact to avoid undue stress. We can either repeat the screening test or we can perform a diagnostic test to confirm or refute the finding of the screening test in question. If the risk happens to be rather above the prevalence threshold, we can be more certain of the test result, and counseling should reflect this fact. And resource allocation and ease of access to the healthcare system should be prioritized for this population. I think to some degree we do this instinctively, but we don't necessarily understand why. This is what is at the core essentially of clinical judgment, right? You have a sense, you have a feeling that, yeah, there's something off about this patient, something about this history is bothering me. I'm going to just send for this particular test and interpret that test in the context of my thoughts about that patient in the first place. So to conclude, screening is a critical part of our daily practice. A screening test reliability really depends on the patient profile and the test, yes, but equally as important on how common or rare the disease being screened for is. Even with excellent screening and test parameters, a rare condition will yield a high rate of false positive results. And this has significant implications on patient counseling, resource allocation, and actually healthcare access. And truly, in cases of a pandemic, it has, for example, significant societal and economic implications. And I think COVID provides a really, truly wonderful example of that. The prevalence threshold is a simple formula that uses a test sensitivity and specificity, which are well known, to determine the risk or the prevalence level below which that screening test starts to quote unquote fail more exponentially, yielding significant false positive results, what is known as a type 1 error. And to enhance the reliability of the screening process, we can either develop better performing tests, which again, there's a limitation to that, right? And that's exactly what we've talked about today, or rather adopt a risk-based screening approach, a step, for example, in our specialty and others have begun to take, in our case, for example, in terms of cervical cancer screening. In the meantime, counseling patients who screen positive should account for the nuanced impact of prior risk and prevalence. So I'll leave you with a few questions for future directions. Could we, for example, use this threshold and have it reverse engineer to better estimate where a person falls on the risk spectrum? Could we envision, for example, a scenario where public health programs save money, run smoother, allow faster access, and serve the true population target by accounting for the threshold? Could we potentially even modify the notion of a risk factor by accounting for risk factors that push the individual beyond the threshold and therefore provide more reliable results? These are things that essentially I think time will tell as we get this idea out there. But I think the main benefit would be really to change the mindset with which we are interpreting a screening test result, because many of us have made the mistake sometimes of really not accounting for extrinsic factors and simply looking at a test result and saying, okay, no, this is what it is, and there's nothing else. So I want to thank you very much for listening. I realized that was a lot of information and I tend to speak a little fast, but I'm very happy now to take any questions. You can find me on Twitter, or if you have any follow-up comments or questions, you feel free to email me, and you can see my email address there. Thank you very much.
Yeah, thanks.
Sorry, I think you're cutting.
Yeah, sorry about that. I had to move my computer. There's a question in the room here, and then I know Julia has a question in chat as well. So we'll start here in the room.
Perfect.
Oh, thank you, Dr. Balayla. My first question is for your fundamental screening theorem. So when epsilon tends to 2, so I understand that both specificity and sensitivity are approaching 1, but
yeah.
Could we look at the slide of your main equation?
Sorry, I'm coming. Where is? I can't. Sorry, it's just because I have the other thing below. 1 second. Oh, let's see. This is why. Yeah, there you go.
Thank you. Could we go to the previous slide, please? Just
the previous slide. Yeah.
One more, where the equation is, your fundamental equation.
It's here.
Oh, yeah, I know. That's kind of like the theorem, but could we see the equation itself, the rho of phi? Just
yeah, rho phi is this. It's the same equation that I was talking about before. It's the screening equation.
Oh, yeah. So my comment is that I think we only need B to tend to 1, because when B approaches 1,
yes,
the full function becomes constant, right?
You're absolutely correct. You're absolutely correct. The problem is that that's if you want it to reach to 1. But the point is that as the sum goes to 2, it might be 1.8, it might be 1.9. The sensitivity can actually also contribute to the area under the curve. I fully admit to a lesser degree based on the way the equation is, but you are correct. Essentially, if we bring this, let me share this slide so that you can see, and I can show you exactly what you're mentioning, because you're absolutely correct. If you bring this here to 1, you're right. Look at my sensitivity. Oh, zoot, I made a mistake. Oh, here we go. My sensitivity, I can move it all the way to 70%, for example, and you're right, it does not change. But look at what happens when I move my specificity. And if you look at, if I increase my sensitivity, the area is still increasing. You understand? So you're right that you don't need the 2 of them to go to 1. But the fact is that's why it's written as a limit. Oh. As in, like, as they both approach to the idea of 1, then you get essentially a higher area under the curve.
Okay, thank you. One last question.
Yeah.
This is more like for application. So your work, how would you like it to be used in the clinic in a regular basis? What would be the ideal for you?
The idea for me would be essentially to, and I do this actually quite a bit in prenatal screening, where we have age-specific prevalence of any sort of trisomy 21, 18, 13. And we have the sensitivity and specificity parameters of the NIPT test, the non-invasive prenatal test. Essentially, it gives me an extra, when I get, for example, a positive test, it gives me even an extra argument to reassure the patient that we might be looking essentially at a false positive. That's not to say that it stops there, don't worry about it, let's not do diagnostic testing. But it is more in my in the stress that I convey, in the urgency that I convey, and in the degree to which I make somebody, for example, access care faster versus somebody that might actually be, I don't know, removed out of a list because somebody else needs to be seen quicker. It's a triage measure. It's a measure to enhance, I think, clinical judgment in the way that we see. Does it have any clinical applications to the degree that, for example, I'm ready to say, okay, no, we'll stop screening based on some subjective notion of risk? No, but my hope is that as this idea gets sort of out there, that it is in fact a potentially important way to reduce cluttering in a system that is otherwise overcrowded and on the verge of collapse. That's more what I was thinking at.
Thank you very much.
Thank you.
Yeah, and I know that Julia, you had a question. If you maybe, I think there's a few enough of us here. I think you can unmute and ask the question.
Yeah, sure.
Yeah, thanks for that, Jacques. I I really enjoyed your presentation. I found it very thought-provoking, and it just made me think a lot about a lot of false dichotomies we make and how abstract the idea of risk is. But really, this follows along with the last question really nicely, and with your last statement. I just wonder, so you should show this in some kind of clinical model. So have you done this? Have you used any clinical data to validate this, to see if you can improve, or if there's any, not only what the impacts are clinically, but in, others, even patient satisfaction in general? You're talking about how you communicate things that would be enough for me to have something extra to think about how this has applications.
Absolutely. So we are currently working on a study, which again, my specialty being obstetrics, where we are assessing essentially, first of all, whether the rates of true positive and false positive results for NIPTs even correspond clinically to what the amniocentesis, for example, is showing, like the diagnostic testing after, whether we can even predict based on the data that we have what the risk is going to be in an individual. After that, we plan on applying the prevalence threshold once we have the confidence, in fact, that the data that is published actually applies to our population, to then maybe incorporate it more clinically. We don't have that set up quite yet. This is all certainly quite new within the last year, but it is in the plans. So thank you for the comment.
Thank you.
Yeah, John, you can go ahead and unmute yourself and ask.
Yeah, thank you, Jacques. Thank you. I understood probably 50% of what you said.
Hi, Dr. Barrett. How are you?
Nice to see you.
Nice to see you too.
Thanks for coming up. So I mean, you kind of answered the question, and sort of, I've known it for a long time, and I've used it similarly. So if I get a positive NIPT for trisomy 15 or 18 or 13, 50% are going to be normal because the prevalence is so right. So and that was my question. In your screening examples, you used population rates in terms of correction factors, whereas the population rates are sort of might not be the right rate to use. For example, colon cancer, the rate that you would use, it would be specific risk in that population. It might, if it's somebody over the age of 70 with three family relatives of cancer, then your population risk wouldn't be the right number to correct.
You're absolutely correct. The only reason I brought those up is because they're public health programs that are done indiscriminately at the population level.
Right. Okay.
Obviously, that individual might fall somewhere different in the spectrum, but when you do it indiscriminately, you're catching a whole. And the question then becomes, is that a smart way to go on about screening in the context that we have these Bayesian limitations that prevalence show?
So what I hoped you were going to tell me, and maybe we have to ask you back, because obviously you're the only person who's smart enough. Well, you're not the only person. Well, you're one of the smartest people I know to do this.
Sweet.
To tell me how to do this, something I wanted to do for my whole life, how to use this kind of logic like Bayesian pretest probability so that we don't have to do such big randomized controlled trials or studies. Because we spend a whole lot of time in research ignoring what we already know. In fact, ignoring what the data already shows us about the trial.
Absolutely.
And we end up doing trials that are costing billions of dollars, take 25 years. Whereas if we use this test, we could do half the studies in half the thing, but nobody accepts this yet. The journal editors are still fixed on p-values and sample sizes where it makes no sense because we're ignoring this whole theory. Which intuitively makes much more sense, but you can't do it because it's like the holy grail of randomized trials. So that's
it is a fantastic question and one that I am not an authority on for the answer, but I can tell you that from sort of the sidelines, there is a huge shift, and maybe you've seen it on all your subspecialties towards Bayesian methods for research, precisely because accounting for priors essentially gives you some value that you otherwise wouldn't get, or that you otherwise would have to buy somewhere else by, like you said, taking on humongous cohorts for millions of dollars and a ton of time. I would have to think about how to apply a concept like this in more an experimental setting where you're studying a particular outcome. I don't have a better answer for you now, but
I'll tell you how we should do it. We should take some of the landmark trials in obstetrics.
You mean
go back before the trial was done and say, if we would have used Bayesian, or if we would have used, say, the interim analysis data. So we can go back to, say, the twin birth study, my twin birth study. If we would have given if we would have, broken the broken the rule and given somebody the interim analysis data using Bayesian theory, how much money and how much time we would have saved.
That's a fantastic question. I'd love to talk to you more about that if you're interested.
Because we've got plenty data from plenty trials. We've got the term prompt study, we've got the breach trial, we've got and I'm sure many people have got other sort of randomized trials in which we did that's what I want to do. I want to take a pretest probability and then redesign and say, if we would have done this, look how much we would have saved.
That is a phenomenal idea. I'd love to talk to you more about it for sure.
Okay, thanks, Jeff.
Thank you, Dr. Barrett. I think there was Dr. Razan also had a question, I believe, if I saw.
Okay. Yeah, I had one quick question, Jacques. I'm mathematically like this area because everything's based on the same measure, so you get all these connections, right? And you can see that so well in the geometry that you lined out. Have you ever looked at a false positive, false negative ratio? I'm not sure if that's a metric that's used that much, but I'm curious if that has a relationship again, because we know that
sorry, Aaron, you cut there a little bit. Have I looked at what?
Sorry, if you've ever looked at a ratio, the false negative testing, and if it had a relationship to the prevalence threshold.
Sorry, it's just cutting. Have I looked at the ratio of false positive?
Yeah, sorry.
I think it's the echo in the room. I apologize.
Yeah, can you hear me now?
Yes, better.
Okay, if you looked at a ratio between the false positives and false negatives, and if that had a relationship with the prevalence threshold, I didn't know if the false positive, false negative ratio was what was a metric you'd looked at it.
Interesting. No, actually, I have not. But that would be an interesting way to look at to see whether there's any sort of relationship between that. It's not something that I've thought of. Because then again, for things that have very, very low prevalence, your rate of false negatives are essentially nil. I mean, to the degree that the data shows. And so if you're doing, essentially what you would probably get is something close to either, if you're looking of the false positive or the false negative, essentially you're getting the false positive rate as a ratio. That is related to the prevalence threshold in the way that I described now, but I haven't looked at the specific data for that. Specifically, no.
Okay, thanks.
It's a good idea though, I think. Thank you.
Thank you, Jacques, for the presentation. Very, very fascinating. Can you hear me well?
Yes, very well, thank you.
Good. So one suggestion for you, and maybe you have done it already, one place where this might turn useful is to provide some support to guideline groups recommending about screening. And more often, as you were mentioning, screening is linked to age or anyways baseline risk assessment, but it's done in a very variable way. So not saying that necessarily want us to use the threshold you are proposing, but that would be a standardized way of showing where there is mathematical change in the probability, and then one might justify why going above or below, and calculating that threshold for different groups and deciding where to recommend, where to not. Have you considered working with guideline groups?
So it is certainly a part of the future, and I think directions that we want to take this on. We wanted to look essentially at we wanted to actually even study this with fetal tracings. Okay, we get tons of false positive fetal tracings, even in women that are generally speaking healthy and have pregnancies that are otherwise evolved well. One of the plans that we have to look at is actually applying this threshold, like Dr. Barrett was saying, in a specifically high-risk population and see whether the probability changes versus that of the general population, and then compare essentially the yield of the test to say, well, is this something that, when you take account cost, you take account the stress, you take account the resource allocation, that we should be doing indiscriminately. And the only way to prove that is if you have, like you're saying, these cohort groups where you're doing the applications of the statistical parameters in one that is sort of higher risk and is known to be higher risk, and the other one in the lower risk. The issue, as I'm sure you know, and I think, I believe it was Dr. Muraca that was saying that before, essentially is risk is a very abstract concept. And it's essentially, how do you establish somebody in the baseline risk? Now, there are some, in fact, I believe there's a study out of Mike Masters, if I'm not mistaken, that have looked at ways essentially to categorize people into what risk category are depending on the pretest probability result. We haven't actually, like I said, applied this yet. This is still not proof of concept because it's mathematics. I mean, it follows, but it's deductive, but it's not something that we have applied to that to clinically yet. And that's sort of in the next 6 months what we hope to do.
Okay, we're past 1 o'clock, so last chance for any questions.
I was wondering, just quickly, we're often reminded how positive and negative predictive values are affected by prevalence, but to some extent, also sensitivity and specificity are. Did you take this into account, or did you assume a constant
So
specificity?
this is, I think you would agree with me, a point of controversy. The question then becomes really, is the disease you're testing for the same? That is to say, is colorectal cancer the same in India as it is in England? I have a hard time suspecting that it is not, which theoretically therefore should not modify or should not change the sensitivity and the specificity parameters. However, the application of the test may be different in two areas. And as I alluded to in the presentation, I think human error, human factors will sometimes change the parameters of sensitivity and specificity between a center and the next. We see this often in fertility, where some centers do have better outcomes than others, even though they're using the same technology. Might be a question of technique or patient population. To my knowledge and my understanding and my readings, sensitivity and specificity are not supposed to be affected by pretest probability or prevalence, but I suspect that there might be some modified factors. Like I said, based on the population that you're testing. It's not something that we've looked at, unfortunately.
Thank you, and congrats on the presentation.
Oh, thank you. Thank you all very much for listening. Like I said, you have my email address there and my Twitter handle. If you guys are on Twitter, whatever you want, with pleasure to answer any further questions.
Yes, and we did record this, so it'll go back on the, I believe, the department YouTube.
Okay, fantastic.
Next week. So if anyone if anyone missed it, would like to see it, I know we had a couple of people ask about it, so we can direct them there as well.
Fantastic. Well, thank you guys very much.
All right. Thanks everyone for coming. Have a great rest of your day.
Thank you.
Bye.